Hello, my friend, and welcome back to the podcast. Today, I have the unique honor and privilege to interview Dr. Kelly Casperson. If you are in the menopausal space, you have probably heard of her. Dr. Kelly Casperson is a board-certified urologist, best-selling author, and top-ranked international podcaster, empowering women to take control of their health, hormones, and sexuality. Known for blending science with storytelling, she transforms complex medical topics into relatable, actionable insights that help many women live fully and fearlessly, especially in midlife. With her signature candor and evidence-based clarity, Dr. Casperson dismantles long-held myths around sex, menopause, and desire. Many of those we will get into on today's podcast. Her acclaimed podcast, You Are Not Broken, has become a go-to resource for hundreds of thousands of women seeking real answers about their bodies and brains. Her groundbreaking work integrates urology, neuroscience, and mindset coaching to drive lasting change in intimacy, confidence, and overall well-being. As a keynote speaker and educator, Dr. Casperson challenges outdated norms in medicine while holding bold, science-backed beliefs and solutions. She's on a mission to build a world where women are educated, empowered, and no longer afraid of their bodies. Whether she's on stage, in clinic, or behind the mic, Dr. Casperson is leading a health revolution, one smart, honest conversation at a time. I will tell you, ladies, we get into the nitty-gritty about hormone therapy, hormone replacement therapy, when you should consider starting, if you should consider stopping, if it's too late to start. We get into all the nitty-gritty, including how to dose it in this episode. I have learned myself so much from watching Dr. Casperson on Instagram and following her throughout the years, and I'm very excited for her new book, The Menopause Moment, which will be out when this podcast airs. Please enjoy my conversation with Dr. Kelly Casperson. All right, listeners, I have an amazing guest for you today. If you heard in the intro, Dr. Kelly Casperson. I just have to tell you, Kelly, I just feel like I know you. I follow you everywhere. I saw the M Factor last week and you were in it. And I'm like, I know her. I was in the audience, so excited. Your podcast is amazing. I can't wait to read your new book, which I hope we get into. Loved that you are such an advocate, a vocal, passionate advocate for women. And I watched you at the FDA with all your colleagues talking and fighting for better hormonal care, just better women's care. So I know we could take this conversation in so many ways. We're also trained at the same coaching school for mindset. And so just want to open up the conversation and welcome you to the show.
Thank you for having me. I'm excited.
Yeah.
We have a lot to talk about.
Yeah. So I know before we started recording, we kind of talked about okay, hormones are important, but the meat of the matter for a lot of things is mindset. Why did you go into mindset coaching as a surgeon, as somebody so accomplished in their career? And why did that work, mindset work, call
who
to
needs
you?
the woo, right? Who needs the woo when you've got all that? I always joke that sex got me into coaching and truthfully, sex got me into hormones too, because I'm a urologist. For people who don't know, that's a surgical subspecialty of the kidneys, adrenals, ureters, bladder, genitals, the genital urinary pelvic stuff, right? And I really got interested in helping women with sexual health after a patient basically changed my life because she was crying in my office and I realized I didn't know how to help her. So I deep dove into female sexual health, female sexual function, what works, what doesn't, what myths do we have, all this stuff. And I'm like, hold on. I can make you have a pretty good pelvis. Like, we can get you to pelvic floor physical therapy, work on your muscle tightness. I can give you some vaginal estrogen. We can get you the right lube. I got great vibrators. But if you think sex is dirty, shameful, takes forever, you're not worth it, you're too tired, it takes too long, all X, Y, and Z, it doesn't matter how good your pelvis is. You're going to have a shitty sex life. And so I started to pay attention to that of what makes some people so curious and open to this topic, and what makes some people be like, it's bad, it's icky, I don't want to touch myself, I got to clean up my body issues first. What makes those two different people, and how do you do that magic of switching to open, curious, be willing to fail, blah, blah, blah. And so that was I was coaching and I was like, I want to do the magic. Right. And so then I was like listening to the podcast, and then I was like, I think I kind of want to do the magic and challenge people on it. And Brooke Castillo, who's our main instructor, like she's an Enneagram 8, like I am. Like she thinks very surgically. And so it really resonated with me. And so now I'm like, my whole life is because I can do thought work. I can challenge my thoughts. Like I had some sticky thoughts I needed to work on before I'm like this decently well-developed human in front of you. And when you learn that your thoughts create your feelings, which create your actions, which create your results, I'm like, shit, I'm a surgeon. Our only feeling is tight, right? And now I look back on that and I'm like, that's true. You know, in all of this, like you learn to feel your feelings. And I think stopping drinking, right? I did that because of coaching. And it's just so monumentally of a game changer that you're like, how can we get our kids to know this?
Absolutely.
Like we got to move it. We got to move it down the hill.
Yeah. Yeah. And like you were just saying, I know when people feel dirty or shameful, whether around drinking, whether around sex, some of that could come from religion, or I wasn't allowed to be that, or women weren't thought of that way, or I learned different practices around the bedroom where sex was bad. And you're right. A lot of it does start in our mind. And we don't realize that because we're just bathed in those beliefs. And when we're brought up, that we don't even think to challenge them as adults. We don't even know that that's a thing.
And like, you know, Brooke just says it so well. She's like, you are afraid of feeling a feeling. And people are like, yeah, but it's a bad feeling. Well, yeah, but you're just afraid of feeling a feeling. You're not going to die. Right. Like, and once you get there, like, yeah, I hate the feeling of shame. It feels really shitty. But then you're like, that's a feeling. This is how it feels. It happens when X, Y, and Z. And you get like a handle around it. And I talk like you're able to like walk around it. Right.
Yeah.
Like right now, shame is present. But like people truly are. They live their whole life so they don't feel something.
Right.
And you're like, when you actually can walk around that, you're like, whoa, what a jail.
Yes. And that's use alcohol to numb and not feel for a lot of people.
Oh, totally.
Yeah. Or to change the feeling.
I don't want to feel awkward.
Yeah.
Right. Or I want to feel relaxed.
Yes.
Right. And like being able to walk all around those feelings of like, oh my God, learn how to feel your feelings. You can accomplish anything.
That's right. So let's pivot. Let's talk about, I just loved what you did at the FDA in challenging testosterone and the women in the room and the advocates talking about the black box label. Where do you see the greatest myths with hormone replacement therapy that still exist?
Oh, that it's bad for you.
Yeah.
That it's not, that it's not necessary, that living 40 years without functioning hormones is normal or healthy, that you shouldn't use hormones until you're suffering enough, whatever that artificial bar of enough is. You shouldn't use it for prevention. You should only use it once you're sick. Like testosterone's a male hormone. Testosterone's only for libido. Testosterone will give you a beard and a penis. All of the inaccuracies of the box warning, right, which are all wrong. So that, that estrogen will cause clots, dementia, heart disease, liver failure, like that's all wrong. So yeah, I was just on a podcast and somebody's like, why are you like especially testosterone, right? Like it's got so many issues, that it's addictive, that all these myths. They're like, why are you testosterone's advocate? Because testosterone's hard. And I'm like, I don't know. Like I root for the underdog. Like,
yeah,
I'm an Enneagram 8. I can't help myself. But it's like, dude, there's a lot of uphill battles. But at the end of the day, I'm a clinician. I take care of women. I prescribe them hormones. I see how they feel afterwards. And so it's like, who better to be like, this is actually what I see and how they feel better, right? Like, I don't need a scientific paper for that. There is so much expertise in being a clinician, being boots on the ground, and seeing like these myths are simply myths, but they're holding everybody else back because nobody's challenging. Why? Show me that data. Prove to me it's dangerous. Like women aren't asking that one next question. They just take it as dogma. And I'm like, dude, ask. Yeah. When a doctor's like, I can't give you that because it's going to cause heart disease. Oh, what's my risk of heart disease? Do you have a paper to show me that increases my risk? Like just ask one more question and like the house of cards falls. And I know as a physician, I'm telling people to ask their doctors. I mean it in a very collaborative, friendly, like, oh, that's interesting that you say that. These other sources say no. anything you'd like to refer me to so I can read more into that. Like in a collaborative, not in a threatening, like cite your sources sort of way.
Yeah. Yeah.
But
Absolutely.
so much of this is myth that just falls apart with education.
Yes, it does. And I was just recently around a bunch of women who said they've been through menopause, right? They're in their late 50s, early 60s. And they say, oh, I didn't need hormone replacement therapy because I didn't have hot flashes or my hot flashes weren't that bad. And I'm like, but it's not just hot flashes. Like there's so many other symptoms.
How are your bones doing? How's your sleep? Right. And what I find is a lot of women are like, oh, I didn't have any symptoms. Yeah, you did. Once you started talking to them, for the most part, yeah, you did. 80% of women do. And they're like, I didn't know that was a symptom of low hormones. So that tends to be the more accurate answer than I didn't have any symptoms.
Yeah. And what are the ones specifically you think most women kind of discount as a hormone thing and think of maybe depression, I'm thinking, or anxiety?
Depression, especially in perimenopause, recurrent urinary tract infections, pain with sex, certainly thinning of bones, osteopenia, osteoporosis, which you can't feel, right?
Right.
Sleep is a really big one. All of a sudden, your teeth start getting worse. You start getting gum disease. Heart palpitations. Number one reason that a woman in her 50s visits the cardiologist is heart palpitations. Because of low
joint pain.
Joint pain, musculoskeletal syndrome of menopause. Yes. Oh my God, frozen shoulder is literally called the 50-year-old shoulder.
Yeah.
Because average age of menopause is 51.
Yeah.
Right. So it's like all these things, but if you don't have the education that every single cell in your body uses estrogen and testosterone to function properly, and if you just think this is you not having periods, you don't understand it's body literacy, right? And it's like we aren't very good at body literacy.
Yeah, they have been pigeonholed as sex hormones, right? They're just for sex or hot flashes. Which is awful. Yes.
Because you can't say that on Instagram. Can't say sex on Instagram.
Oh, so, interesting.
Yeah. And so like it also downplays the importance of these hormones on the brain, on the heart, on the bones. Prevention of it. If there was a medication that decreased your risk of diabetes by 30% in perimenopause, don't you think it would have a Super Bowl ad? Yes,
right.
Except for it's called estradiol, and it's a generic, cheap medication, so it will never have a Super Bowl ad. But it's like, dude, they're looking for the holy grail of diabetes prevention in this country. And they've got randomized placebo-controlled trials showing that when started in perimenopause, pre-diabetics, so you're already pre-diabetic, you're already at risk. Within 1 year, have a 30% decreased risk of turning into diabetes when you're on estradiol. This is metabolic health, like stuff you can't feel.
Yes. Yeah. Yeah. And stuff you may not know is happening, like you said, until you look at your markers or go to your doctor and get labs. And I'm such an advocate of looking at labs and, your symptoms too, right? But just lab work as well, because it can tell us so much.
Yeah.
When you're replacing these components back, these natural components that our body makes, estrogen, progesterone, testosterone, do you have a sequence of which you like to put back first?
It depends upon what her issues are. Because I want her to notice improvement, right? And so to me, I'm like, what's bothering you the most? Is it sleep? Then I'm probably going to pick estrogen, progesterone. Is it energy? I'll probably pick energy, libido. Then I'll probably pick testosterone first, especially in a perimenopausal woman. Because if you're perimenopausal, you'll still be getting some estrogen spikes, but progesterone and testosterone tends to be lower. So it depends how old are they, what are their symptoms. Hormone therapy is not cookie cutter.
Yeah.
Is it mostly genital urinary syndrome for you? Then I'm going to start vaginal estrogen first. So it's individualized.
Yeah. And then what is your thoughts about this timing hypothesis that you need to start it within 10 years of your last menstrual cycle? And then I'm going to follow up to that as like, how long should women be on it? Like, what is your thought about the timing hypothesis?
Yeah, it's a great question. So timing hypothesis basically means hormones are better at preventing disease than treating disease. And for example, on the horrible day that you or a loved one gets diagnosed with dementia, it didn't happen that Tuesday. It happened 20 years ago. And it just slowly started enough until you have signs of dementia. And so what that means is if you want hormones to do their best job of decreasing the risk of neurologic disorders, cardiovascular disease, you have to start before the changes already happened. And so that's within 10 years of menopause is roughly, and that was decided because of the WHI and just how they split the numbers up. There's no magic, like 10 years in 1 day, 9 years and 11 months, right? It becomes arbitrary at some point, but they kind of diced people into age groups. So that's for prevention of disease. That doesn't mean hormones won't work when you're older. It doesn't mean you don't have a chance for starting them. It just means when so about a third of my practice is women in their 70s. So I tell them, I'm like, hormones will still help you. These women they're still having hot flashes. They're still sleeping poorly. They still have mood issues. They still have insulin resistance. Like, it's not like they're doing fine over here, right? But I say, probably won't get the benefits of prevention because we didn't start earlier. But you're still going to get the symptomatic improvements of it's helping me with sleep, it's helping me with mood, it's protecting my bones, stuff like that. But what people have done is they've taken the timing hypothesis and they've said you can't start after a certain age. That's not true. Transdermal estradiol is incredibly safe. No increased risk of stroke, no increased risk of heart disease, no increased risk of blood clot. So when people say, again, this is challenging your providers who might not be educated, you can't start because of your age, say, oh, would you like to share the data? Would you like to share the guideline that says you can't start? Because there is no guideline that says you cannot start after a certain age. The Menopause Society Guideline 2022 says benefits outweigh the risks when started within 10 years. And then after that, it's a risk-benefit discussion with your provider. So people have taken that to draw a very harsh line where it doesn't actually exist.
Yeah. Yeah. They made inferences when it doesn't have data. Right. Yeah. I'm with you all the way. When I see women that are older and they're like, I don't know if I should be on HRT. I say, oh, you should talk to your provider. And here's what I would consider, even at your age, and because of these benefits that you can still gain, right, when you're starting it. How about for women? I was just walking with a friend who said, oh, my provider says I'm now 65 and it's time to come off my hormones.
Oh, God, no.
Yes. That's what she said to me. There's
actually a really good paper. It's like a year or two ago now. And they looked at, so entrance to Medicare in America is age 65, right? So they looked at on admission to Medicare, how are the women doing who are on hormones versus who've stopped hormones or didn't start hormones? So this is the first piece of data to look at. They're doing much better in most domains of like decreased heart disease, a little bit of decreased dementia, a little bit of decreased breast cancer. Like, they're doing very well. And so the question is, why would that all of a sudden become dangerous or bad 1 day later, 2 months later, right? Like, it gets very arbitrary very quick. We're like, there's no age. Like, age is a drinking limit. Age is a driver's license. Age is a voting thing. Age is not a marker of a health. It cannot stop. It doesn't make any sense. Do we take men's testosterone away when they turn 65? Do we take trans individuals' hormones away when they turn 65? Right? Like, no. So why are we doing this to women?
Right. Do we take thyroid away?
Do you take thyroid? Do you take insulin away? Yeah. Right. Exactly. So it's do we take Viagra away? Right. Yeah. So it really doesn't, the candle doesn't hold up when you start looking at things like that. And so people are like, how long can I keep? So if you're already on it, I always say, what do you want to do when you die? Do you want to be cremated? Do you want to be buried? What's your plan? And that usually trips people up because now they're thinking about how they want to die. But they'll be like, oh, I want to be buried. Great. Take the patch 6 feet under. It's fine. Which is a humorous, memorable way of saying, take it till you're dead.
Yeah.
There's no, and again, 2022 menopause guidelines, because doctors love guidelines. For that person, for your walking friend, go online, print out the 2022 menopause guidelines, and highlight the part that says you can continue. As long as benefits outweigh risks, you can continue this.
There were some interesting facts I learned when I watched the M Factor when it came to San Diego. And I actually got teary-eyed watching some women who have suffered for so long with so many different ailments. And then when they get put on hormone replacement therapy, it's like so life-changing for them. But one of the stats that they mentioned was before the WHI, 40% of women were on hormone replacement therapy.
That's right.
And currently, it's 1.4, 1.7% that take hormone replacement therapy. Yeah. So even though this study that came out in 2002, it's now 23 years later, and the data has been reanalyzed, the data has been walked back, that it doesn't cause all these downstream effects that we thought it did, that there's actually protective benefit. Women have better brains, better bones, better cardiovascular health, more heart protective, 43% risk reduction in cardiovascular events, the number one killer for women. Like, all of these things that have been now in medical journals for years, but yet the measuring stick is still so far low. it really made me pause and go, what are we doing? Like, how can we get this number up? What are some of the things that you
on
are
the ground
thinking?
education podcasts like this?
Yeah.
Like we can change it in two ways. We can change it top down, or we can change it bottom up, right? And I really think of this and what I'm doing as advocacy very similar to the ACT UP movement with HIV and AIDS, because the world was moving slow. People were suffering. They're like, the government's not moving fast enough. The doctors aren't moving fast enough. We need to move. So it was really bottom up that changed, like, let's have some more options for this. And that's what's happening now, because to change medical education from the top down is very slow and it's very hard. But if a doctor has 5 people come in this week saying, I want vaginal estrogen, hey, I'd like to consider testosterone for my low libido or blah, 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 or whatever. They're like, hold on, I need to learn how to do this. Right. So that's how it's changing. And I would say I've been doing this now for, I mean, it's not that long, but even in the last 4 years, it is groundswell of change. So, but it takes everybody. We got to educate the pharmacists.
Yeah.
Like a woman sees a doctor, the doctor gives her a prescription, the prescription goes to the pharmacy says, this is going to kill you, I can't. Or the pharmacist says, you can't be on both transdermal estrogen and vaginal estrogen. Or the pharmacist asks the woman, are you planning to transition? What's your plan with testosterone? Like, really rude, invasive questions in public that is none of their business. So, and by the way that the pharmacists have to put a carcinogenic label on estradiol because it's labeled as a carcinogen is absolutely insanity. So there's a lot of work that has to be done in the pharmacy world. And when I get vocal about this, the pharmacists are like, not all pharmacists. And I'm like, I know.
Right.
But it's another barrier
Yeah.
for women to get healthcare.
Absolutely. Absolutely. Yeah. It's just like not all doctors, right? But there are some, right, that still need education. I was just at a clinic seeing a patient who wanted weight loss, and she was a prime candidate for HRT. And when I brought it up to her, she was so resistant. And I said, that's fine. But here, I just want you to know some facts. Here's what we now know. And so I walked her through it. By the end of the appointment, after I've been with her an hour, she's like, well, can you talk to me about that HRT again? What does that look like? How would I do it? And I said, okay, I'm on it. And I showed her what I do and then opened her up. But then I had to train the doctor how to write for it because he had no idea. He doesn't do HRT. And so I was training him and learning too, because it's not something that I do often, but yeah, just we're all learning together. And I think that's such a beautiful thing.
Yeah, and weight loss is interesting because there's already Ozempic data, but this was just a new abstract at an endocrine meeting that was tirzepatide data that people who, and this is any gender, so it's true for men with low hormones who are on testosterone and women with menopause, perimenopause who are on HRT, is the GLP-1 is more weight loss and more preservation of lean body mass. And the tirzepatide data is 35% more weight loss when on the combo of hormone therapy and GLP-1s because they're synergistic. Right? Hormones help the cells function better so they can actually do their job better to preserve the lean body mass and to help the metabolic dysfunction while the tirzepatide is doing the tirzepatide stuff. So to me, I'm like, anybody who's interested in weight loss needs to know that data. 35% is a large number.
Yes, absolutely. Absolutely. Let's transition to your new book.
Okay.
The Menopause Moment. Yeah. Tell us why you wanted to write this book and tell our listeners about it.
I think going back to the beginning of this conversation, there's just so many myths out there. And I just wanted a place where I could just put it all and be like, go read it. I'm here for follow-up questions. Because a lot of what I do, being an expert, is being okay with saying the same thing over and over and over again. And at some point you're like, okay, this is enough for a book. But my first book, You Are Not Broken, is all about women's sexual function, sexual health, adult sex ed. And the publishers were like, will you write another sex book? And I'm like, I kind of want to write a menopause book. And they're like, okay, write that. Because the menopause was starting to take off. And I really think of my book as the 2.0 because most people at this point are getting to, there's still a lot, like you said, less than 5% of people are on hormones, but we're getting to the point where like, I've heard of that. I hear it's safe. How do I advocate? How do I talk to my male partner about this? How do I talk to my doctor about this? What's up with weightlifting? Is alcohol bad? So I have an alcohol chapter. I have a weightlifting chapter. I have a how to talk to your doctor chapter, how to talk to your male, how to talk to the men. All you have to do is say it's like your testicles fall off. And then they're like, oh, okay, got it. How can I help? So it's very simple to talk to the men. And I wanted all of that in there. And I wanted people, because so many people are like, we just need more research. We need more research. And I'm like, listen, have you looked around? There's not a lot of research happening right now. Don't hold your breath for more. And by the way, we actually have a lot of good research. Let's just know it and use it. Right? Because if you just sit around saying, you know what, we can't until we get more research, well, you're going to be dead.
Yeah.
Like it's just an unacceptable statement at this point.
Yeah.
We got to use what we have.
Yeah. So let's empower the listeners, because if you're a woman listening to this and you're really curious about bioidentical hormone replacement therapy for longevity, for your wellness, for protection of the bone, the brain, everything that it does, like you mentioned, there's estrogen and progesterone receptors on cells throughout the body. I know you mentioned some good strategies about, hey, just ask another question when they say, no, I don't do this. But any other advice you would give to somebody who doesn't have a practitioner who's maybe open-minded or willing to consider this?
Yeah, I'd use the online clinics now. There's many great ones. Alloy, MIDI, Interlude's great just for vaginal estrogen. Interlude's awesome. Code not broken, I think, for 20% off on that one. What else? Genev, Evernow. Those are all online hormone clinics. And the nice thing about it is that's what they do. They do hormones, which we need. We have 80 million women over the age 40. We need resources to help these people. And 100% of them will have low hormones. Right. This is not a rare problem.
Right.
So, yeah. And the other thing is they're like, what do you do when you go in and your doctor says no? It's like, talk to a receptionist ahead of time. Don't even make an appointment. Like, does this doctor treat menopause, perimenopause, testosterone for women, genital urinary syndrome of menopause with vaginal estrogen, whatever your issue is, ask it ahead of time. Because don't pay for parking, take the day off of work, do a copay to be, oh, I don't do that. I don't believe in that. Find that out ahead of time. Just save yourself some trouble. And in America, we have the great fortune of getting a second opinion. In Canada, it's not that easy. Right? So it's like, take the great fortune of living in our healthcare system to go see somebody else who does this for a living. And it's hard. It's hard. Like, doctors are overstretched. You only have 10 minutes with people. You don't get your education in clinic anymore. You don't have time. Right? So it's like, learn what you can ahead of time. Partner with somebody who's willing to try things with you. Seek outside, and concierge care is sometimes the option, at least to dial you in, and then get dialed in, go get your refills from your primary care doctor, whatever. But like somebody who actually has the time to work with you, especially in perimenopause, because perimenopause is a roller coaster, right? Like, hormones are changing, whereas postmenopause they're just nice and low, right? So perimenopause is kind of the rougher ride and can be a little bit more time intensive to manage.
Yeah. Do you treat, when you use the hormones, do you treat per certain levels for the different hormones?
Yes and no. Labs in and of themselves are, so people think labs are the 10 commandments, right? They're carved in stone. They're all meaningful. What it says on Tuesday in July is what you're going to be in November. No. Where people are putting too much faith in labs, I care a lot of how do you feel? How do you feel? Do you have any side effects? Okay. Well, no, or you don't feel it, or blah. Let's check a labs. Make sure you're absorbing. Let's check a lab. Okay, you don't want to just not have hot flashes. You want to make sure you're building or protecting bone. All right, the data probably says the estradiol level needs to be a little bit higher then. It's good to know. But so yes and no. I think there's two schools. There's a school of like, don't need labs, just how do you feel? And then there's the other school, which is like, you need $400 labs every single quarter.
Yeah.
Right. And I would say I'm kind of in between of like, I use labs as the tool that they are. I do not give them more power than what they deserve.
Now let's pivot to testosterone, because I know you know a lot about testosterone in women. What are the big symptoms that tell us that we may be low in testosterone, or that testosterone therapy might be helpful for us?
Yeah. So in America, there's no FDA approved indication for testosterone. So whenever I say, oh, it's useful for X, Y, and Z, that is based upon research, which, yes, of course we need more, but we don't have more at this point. So we got to use research, and we got to use clinical experience or clinical expertise. So what are women coming back and telling me? The most data we have for testosterone is in the realm of sexual function, of which libido is one domain of sexual function. But testosterone helps in all domains of sexual function, including arousal, orgasm, like levels of distress with sex life. Testosterone helps all of it. We've got some data that people are able to get off their antidepressants better when they add testosterone to their regimen. So mood. And the other thing we can use is male data, right? So testosterone doesn't just help libido in men, right? Helps depression, actually helps decrease the risk of dementia in men that are low who are treated. We have some bone data. It helps some people sleep. I met a woman at the FDA. She was on enough Ambien to like tranquilize a horse. And she's like, I could not sleep. And when I added testosterone to my regimen, I'm able to sleep. Now, some people can't sleep on testosterone. It's too energizing for some people. But some people, they're like, testosterone, now I'm sleeping. So it's different for everybody, but really understanding testosterone is a neurohormone. It helps your nervous system function. So probably implicated in a lot of, I mean, I think of testosterone as prevention, right? Like we just want our cells working as best they can. And there is compelling data that people who have low testosterone are probably at higher risk for dementia, multiple sclerosis, Parkinson's disease, nervous system disorders. But are we going to get a randomized control trial showing this anytime soon? Absolutely not. It's not going to happen. Don't hold your breath. 5 generations will have passed. But just, I want people to understand we've been giving testosterone to women since the 1940s. We have 80 years of data at this point. So when people hear like it's just for libido, that doesn't even make any sense. Like libido's a mood, right? And it's funny, you put desire into the life coaching school model, you're like, it's a thought, it's an action, it's a circumstance, it's a feeling, it's a result, right? Like it's all the things. Like it's very fun to run the model on desire. Because it's like, where would you like to put desire today?
So true.
So that's super fun. But everybody wants to pigeonhole testosterone, and it's like it literally works on your mitochondria in your cells. That's everywhere in your body. It's not just the one. Where in your brain is the libido box? Is it on the left side or the right side? How big is it? Is it a centimeter or is it an inch? Right? And they're like, oh yeah, no, it's your whole brain because your whole brain's your sex organ. Like the whole brain lights up with sex. So for people to pigeonhole this, like there's just one thing in one spot, is like, that's not how it works. Knock it off. Learn some biochem.
Yeah. A lot of people say they feel energized or they're now motivated when they found like motivation to be hard or they can't get out of bed.
Yeah. Multiple women who've started businesses after starting testosterone.
Yeah.
But we're not going to get an FDA approved indication for starting businesses. Right. It's just so, you have to take all of that with like, this is my clinical experience.
Yeah.
The downsides are few. When dosed appropriately, the side effects are rare. And some people, they light up on it. One of my women, she's like, that part in The Wizard of Oz where it goes from black and white to Technicolor? That's my brain on testosterone. It's just like her brain's back on.
I hear that for women when they say they come off alcohol. Everything was like shades of gray. And then when they come off alcohol, it's like, oh my gosh, my life is amazing. And it's so much more joyful. Yeah.
When I stopped alcohol, I don't remember exactly when this was, but I was like, oh my God, music is more awesome. Like music to me became very cool.
Yeah. Because you're now in touch with your feelings and music can like penetrate your body. Yeah.
Right? Yeah. But you're not like, why should I quit alcohol? Because music's more amazing.
Yeah.
Right. Like it's the same thing with like testosterone. Is like, well, because you'll
start a new business.
Yeah. Because you'll start a business. It's like individual results may vary.
Yeah. And what do you think about formulation for testosterone? What do you like to start patients on?
Yeah. So in America, we do not have an FDA approved dose or formulation for women. So that makes it hard for insurance to cover it. That makes it hard to dose it appropriately. Many people do it in many different ways. You can microdose the male gel, right? So we got gels, you can compound a cream. So it's like 1 pump a day. People do injections, people do pellets. Pellets tend to be the highest dose, most expensive, most invasive. So for that reason, it's not don't start with a pellet because it's the most expensive, highest dose, most invasive. And I'm like, you realize this is like a 40-year plan, right? Like you shouldn't have to remortgage your house for some hormones. And do you want a little incision in your butt for the next 40 years? And women are like, oh, I didn't think about that. And I'm like, well, you should. Right? Like you should think about these things because why do something that's not sustainable? So I always say earn your pellet. Some women do better at higher levels, but not everybody does. So work your way there slowly. If you see somebody who only does pellets, that might be a one-trick pony who's making money off of pellets. Like a true expert's like, here's the menu. This is why I start with this. This is when I go to this. right? There's many different ways to deliver. You can get a compounded troche, which is a sublingual. You're a pharmacist, you know these things.
Yeah.
I have big questions with safety data on that because it's very poorly studied. How much of that is going orally through the liver, which oral testosterone is toxic to the liver unless you get the new FDA-approved male formulations that are metabolized lymphatically, right? So I worry about oral troches, that how much of that is getting in the liver. I don't know. Nope. Very few published data. I have talked to compounding pharmacists about this, and I'm like, send me all of your troche data. And they're like, we don't have any. And I'm like, I know. Like, still waiting. So I don't love troches. I think they're too quick on, too quick off. You maybe need it dosed multiple times a day. We don't have any data. Like, what's the half-life of a troche for somebody? I like standardization, and that's my big issue with the troches and testosterone.
Yeah. One other topic I want to cover is what I hear a lot because of my pharmacist background is how expensive these medications are, right? People like to talk about expense. What do you find when people might bring up that as an objection or a reason not to even look at hormone replacement therapy?
I think expense for many people is an issue, and I don't want to downplay that. But for a lot of people, it's like, you know how much you spend on a cup of coffee every single day, right? If you have cable.
Or a glass of wine.
Or, oh my God.
Right.
Yeah, a drink out. Oh my God. It's like, that's like a month worth of hormones for you. It's like a bottle of wine, right? And so I think part of it, for some people, it's a legitimate problem. We need more insurance coverage. I absolutely agree.
Yeah.
And for other people, I'm not sure they have the priorities straight. Hip fractures, really effing expensive. Dementia, super effing expensive. A heart attack, really effing expensive. Being depressed, financially devastating, right? Like, everything is expensive. Pick your expensive on where you want to put supplements that a lot have very shitty data. That's expensive. And so to me, I'm like, I don't know. I can't pick on hormones as being all that more expensive than anything else. And if it is expensive, you're at the wrong pharmacy or you're using the wrong formulation for the most part. You know, pellets again tend to be the most expensive, and they're not the only option.
Yeah, and some of these are covered by insurance.
Oh yeah.
Right.
Mark Cuban Cost Plus Drugs, you can get a tube of vaginal estrogen for like $15 plus shipping. There's nothing cheaper. Like, it's fantastic.
Yeah.
One urinary tract infection is expensive. And I tell women, if this vaginal estrogen decreases your urinary tract infections by 1, it's paid for itself.
Yeah. And think about all the prevention of disease, prevention of diabetes, prevention of, like you said, the hip fracture. Like, yeah.
Women who are on hormones tend to be on less other medications.
Oh, interesting.
So yeah, to me, I was like, it's like the people who are like, it's not natural. And I'm like, listen, living past 62 is not natural. Like, get over the natural argument. The socks aren't natural. Like, where do you want me to stop with that?
Yeah. Yeah. And look at different options. I think there's a lot of different options out there. Like you were saying, you can get some of these generic, you could get some of these by insurance. Some compounding pharmacies are cheaper than others, even in the area that I've been looking at. And like I found one near my house, but hey, it's not the most cost effective. I found something that's a little bit more cost effective. So work with your provider or make some phone calls around because there are ways you can get this in a more affordable fashion.
Yeah, I mean, I always tell people, like, your insurance now will make money off of you for medications. And so I tell them, I'm like, if these estrogen patches are more than $50 a month, they're making money off of you. Let's move it to a cash-based place. It's going to be cheaper. So Mark Cuban Cost Plus Drugs, HRT Club is a nice place to get prescriptions for cash for cheap. So this whole, like, just because you have insurance, it's not always the cheaper option. Sadly, awfully. That's 2025.
Well, Dr. Kelly Casperson, it's been so amazing having you. Anything else you want to leave our listeners with as we wrap up today?
Just care about your body. Like, get curious about why it functions. Get curious about what your options are. Like, challenge limiting beliefs because it'll change your life.
Yeah. Love that. Love that. Well, I just want to say a huge thank you for myself and all the women and all the generations following me for all the advocacy work you're doing. I love watching you on Instagram. We're going to put all your links in the show notes because you educate so well. I've learned so much from you. I've learned more from you than my own doctor. And I really admire your passion for women and for changing the narrative in this space. Thank you for all you do.
Thanks for having me.
Thanks for listening to the Health Habits and Epic Living podcast. If you're ready to take the next step to improve your health, wellness, and lifestyle goals, head over to www.epicu.com and sign up for my weekly newsletter. Again, that's EPICYOU.com. Please note that the information in this podcast is for educational purposes only and does not constitute medical advice.